Today we're going to be reviewing vascular and cardiac, and I want to go over the quiz. I think a really good way to review for the exam this weekend is to really go through the quiz very thoroughly, and if you have any questions, let me know, but I'll give you some hints as to how to solve each question, and then throughout the quiz we'll hit on some other topics that are going to come up on the exam.
Can you open this for us to look at it?
Yeah, I can, yeah. So we'll go through this. How did everybody feel about the quiz?
Yeah.
Did your Excel
The chart for
chart, did that help out the most? Alright, so have the chart out and maybe a scrap piece of paper. Because we're going to make some notes on this. Alright, first one. What type of pulse sequence are used to obtain black blood imaging? So the first one is all of the above. So remember with black blood imaging, we're usually not able to catch fast flowing blood because we have a 90 and a 180 degree refocusing pulse. So I have this chart, or this PDF document back from when we covered flow, but this really helps to kind of hit home this first question. So most of our blood flow that we're imaging in MRA sequences, where it's really concerned with the arteries, this blood flow is very fast, and these spin echo pulse sequences are too slow to catch flowing blood. So this second little diagram here is a good indicator of why we get black blood imaging with spin echo pulse sequences. Because if a nuclei gets excited, usually it's too fast and it leaves the slice before it actually gets rephased by that 180 degree refocusing pulse. So when that happens, we get no signal from flowing blood. The only time we would usually get signal from flowing blood on a spin echo is with extremely slow blood flow, where there's some kind of stenosis that's clogging up the blood flow, causing it to go slower, or really slow venous blood flow. And that's where this first little drawing would come into play, where the blood flow was able to get excited and rephase within the slice before it actually left. So the answer is all the above, because a fast spin echo, inversion recovery, and a spin echo all have a 90 and a 180. A fast spin echo has a 90 followed by a train of 180s. Inversion starts with a 180 inverting pulse, and then we have a 90 and 180, and usually it's also a train of 180s. And then spin echo, or conventional spin echo, is our 90, 180. So anytime you see this 180, always associate it with black blood imaging, because the blood flow is too fast to image. All right, number 2. In black blood imaging, we are more concerned with the vessel wall pathology as opposed to the flow within the vessel. Is that true or false?
True.
It's true. And what's that called when we're concerned with the vessel wall? Okay. All right, the third one here. A blood clot or occlusion will appear bright on black blood imaging.
True.
True. Why is that true, though?
It's not moving, and it's getting refocused.
And it's getting what?
Refocused.
Refocused, perfect. So it's receiving that 90 and 180. This is true because clot is receiving 90, 180, which equals signal. And this is similar to stationary tissue, because the clot, I think it's staying in one place. So it's similar. Okay. All right, number 4. What can be used to improve blood imaging? How can we make the blood appear darker? Even though it's already black, sometimes we want it even darker so that we see the vessel walls.
Sat pulses outside the fluid.
Sat pulses outside the fluid. So imagine our field of view of the abdomen is red. We can put a sat pulse that's in blue outside the field of view to saturate blood flow coming in. So imagine our blood flow is coming down from the thoracic aorta. Okay, this is arterial blood flow coming into our field of view. If we apply a saturation pulse, which is spatial, meaning we put it in a space, it could either be outside the field of view or inside the field of view. It applies a 90-degree before it enters our field of view, so that when it enters our field of view, it gets another 90 and completely saturates it. So that will make it even darker or black, more black. Space. All right. Number 5. What type of pulse sequences are used to obtain bright blood imaging? So we already established that these are all spin echo pulse sequences. So the only one that is different is our gradient echo or gradient recall echo pulse sequence. What are some other terms to describe a gradient echo pulse sequence? Flow sensitive or flow insensitive? Flow sensitive. So that's a flow sensitive pulse sequence because we have bright blood. All right. So then our next question, in bright blood imaging with gradient echoes, we are more concerned with the flow within the vessel as opposed to the vessel wall pathology.
True.
It's true. And what is that called? Hemodynamics. Good. Hemo, medical abbreviation for blood. All right. Any questions from 1 through 6? Number 7, what can be used to improve bright blood imaging where intravoxel dephasing and phase ghosting artifact are present?
Gradient moment nulling.
Gradient moment nulling. And this is also referred to as what? So gradient moment nulling is usually on our Siemens scanner. So you'll see a GMN on our Siemens. But what do we see on our GE scanner? We're putting our flow back into the vessel. So remember that flow sometimes can streak across our image. Remember seeing that picture of the abdomen where the abdominal aorta streaked across the image? With gradient moment nulling, it repositions it right back into the aorta. So it's higher in signal and we don't get that phase ghosting artifact. What is it called in a GE scanner? It's a little button you can actually hit on for your parameters. parameters chart. You might recognize when I start typing flow compensation. So you'll have that on your GE parameters tab. But here, a gradient moment nulling, we're using a bipolar gradient system. So here's a line for our gradients. And we want to apply a gradient that has a -2 charge, amplitude, and then a +2 amplitude. And that's so that our moving spins have the same phase position as their stationary spins. So we don't actually lose signal from our flowing spins. So if we draw our little clock here, we start off at 12 o'clock, we want to end at 12 o'clock. Okay, that's what these bipolar gradients do, so that we don't have a phase mismapping artifact where it gets put into the wrong row of K-space. Because if it gets put into the wrong row of K-space, it goes through the fast Fourier transformation, that basically that algorithm, that mathematical algorithm, and then it creates the image. But if it had gone into the wrong row of K-space, it streaks across our image in the phase direction. That's why phase mismapping or ghosting artifact happens in the phase direction. So we want this, it basically applies a 2 negative, so it flips at 6 o'clock, and then it continues to dephase and it flips it back to 12 o'clock. So there's no change in phase. We'll talk about the other ones here shortly. But this further increases signal within our vessel. All right, number 8, a blood clot or occlusion will appear bright on bright blood imaging. False. And that is due to saturation. It's going to appear dark So with gradient echo, we have bright blood imaging, which is where we got fresh blood coming into our stack of slices, so it hadn't received those repeated RF pulses. And stationary tissue had, so that's why it appears dark, because it's saturated. So if a blood clot is sitting within that vessel, it's going to sit there also, so it's going to be saturated. So it's going to appear dark. All right, number 9. This is used to cover a large field of view because of less saturation. 2D, good. So 2D time of flight, where would we use that? In the circle of Willis or in the carotids? Carotids, good. So think of 2D time of flight as going up the carotids with slices. And our 2D slices have a gap between them. Compared to a 3D time of flight, which is what we call a slab. So as our blood flow goes from the aortic arch up the carotids, we're going to be able to go through a larger area due to less saturation because we're going through slices as opposed to a slab, where we're going to get more RF pulses through this entire slab. And remember, we can change our slice orientation to go countercurrent to reduce that saturation. And countercurrent meaning where our first slice is going to be this one right here. Second slice is here. Third slice here. And then our fourth slice here. So that we're going countercurrent to the flow. Co-current is where we would have slice 1, 2, 3, 4 that goes with the flow of blood. But that produces more saturation. What are our advantages with 3D? What are our advantages here?
Overlap.
What's that?
You said 3D?
Yeah, what are our advantages with this slab opposed to slices? We're imaging the circle of Willis, right? Does that usually have fast or slow flowing blood? Very fast. So we can image fast blood. We get really good increased SNR because we're exciting in a whole area of tissue as opposed to just exciting one slice at a time. And it gives us better spatial resolution. Because we can typically on a 3D slab get a slice thickness of less than 1 millimeter, which is really good resolution. Because we're not concerned about that cross-excitation artifact where we need the gaps. So if there was a tiny, tiny pathology that was in between the gap right here, we might miss it due to our partial volume artifact. But if that same area right here was right here on a slab, we're going to be able to see it because our image resolution is a lot better. All right. Have we got that written down from 7 to 9? Number 10. This is optimal for faster flowing blood.
3D.
3D, we already talked about that. And that's because our slab, just bringing it back up, you can see here how if we have really fast blood flow, we're going to be able to excite it and rephase it before it's left the slab, as opposed to if it's just excited and then it's already left the slice. So see how much thinner a slice is compared to a slab, but remember, a slab can create thinner slices as a whole. But it's just you can cover a larger area. Or excite a larger area. All right, number 11. What type of sequence is used to visualize a circle of Willis? 3D. And where do we put our sat band on a 3D time of flight? Above circle of Willis. Because we want to saturate the venous blood flow coming back down. So if this is our brain here, here's our corpus callosum. We usually want to cover with our field of view from the corpus callosum down to the foramen magnum. And then we usually want to put our sat band up here. Because we're interested in blood flow coming up from the carotids, but we do not want that venous blood flow coming. Remember that superior sagittal sinus that goes basically on top of the brain is going to come back down. All that blood flow from the superior sagittal sinus. And we do not want that. right, next one. What sequence is used to cover carotid arteries and vertebrals?
2D.
2D. And I put here not just bifurcation because the 3D covers the bifurcation of that area. And a lot of times where those vessels bifurcate or that they split is where the pathology is. So sometimes if you're not able to give the patient gadolinium due to their allergic or they're just scared about gadolinium retention, whatever it might be, sometimes they'll do a 2D of the entire carotids and then they'll do a 3D just through the bifurcation. Do you remember where the bifurcation usually happens at? What level of the C-spine? Bifurcation of the carotids. This usually happens at C4, 5. So if you're imaging and you're counting, and remember with MRI, you're counting starting from C2, because you can't really see C1 that well on the sagittal slice. Start from C2, count 2, 3, 4, 5, 4, 5. That's where you want to look for that bifurcation. Sometimes it might sit a little higher C3 too. So just 3, 4, 5, kind of look in that area, see where that bifurcation, and cover it with your 3D slab. Question 13, to reduce saturation on a 3D time of flight and cover a larger area, what can be selected by the operator?
MOSA and Raptory.
Good. So it's both of these options. What does MOSA stand for? Because that will be a common registry question.
Multiple overlapping thin slice. Thin section.
Multiple overlapping thin section angiography. This is where we get the coverage of 2D with the increased SNR and spatial resolution of 3D. So it's almost the best of both worlds. So with MOSA, imagine you have these 3D slabs. They slightly overlap. That's where we get the name. Multiple overlapping thin slabs. So that we can cover the carotid arteries and the vertebral arteries that run behind it. Two things could go wrong with that, though, and it creates one type of artifact. What's the artifact with MOSA? So you can see here how these look, these thin slabs look like Venetian blinds. So we get that Venetian blind artifact. So I'll just abbreviate it. Venetian blind artifact. This occurs when the patient moves between slabs or saturation issues. So you can see here as the blood flow comes into a slab, it's going to be fresh, but by the time it leaves that slab and goes into the next one, it's going to be a little bit more saturated. So when you have an area where it's almost saturated at the end and then the next slab starts, and it's going to be a little bit brighter. So the blood flow looks like it gets a little darker and then a little brighter, and then a little darker and then a little brighter as it goes up to the circle of Willis. And if the patient moves, it has this, it jumps. So the carotid artery could be going up, and then all of a sudden it moves over a little bit and then continues going up. What does it mean with rant RF? What's changing with the rant? Good. So we have a variable flip angle. So our flip angle starts at like 5 degrees, and then it goes all the way to like 90 degrees. This is a gradient echo, so it doesn't really go up to 90, but it gradually increases as it goes through the slab. And that's all to deal with saturation issues. So as we go through a slab, think a slab is bigger than a slice. We're always having to counteract those saturation issues. So MOTSA and a rant flip angle help to do that. Another name you might see on the registry for a rant flip angle is tone. Now, this means tilt, as in the tilt of the flip angle, optimization, non-saturation, excitation. So that's what tone means. Okay. Everybody got that written down? Question 14. What type of artifact is associated with MOTSA? We already talked about that, but what is it? Good. What can be used to further suppress background signal on circle of Willis? Time of flight projections. Okay. So it's going to be both. So remember, gradient moment nulling, that's to put signal back into the vessel due to those bipolar gradients. But to further suppress background tissue. So that circle of Willis usually looks something like this. And what we're talking about is all that background tissue that is not the vessels. So everything else. The white, the gray matter of the brain, the corpus callosum, the retroorbital fat, the orbits, all those other brain structures that are stationary tissues. But what happens with this stationary tissue sometime is what we call T1 shine through. Meaning tissues that have extremely short T1 values still appear as higher signals on these time of flight projections. Tissues with extremely short T1 values give all signal. So to compensate for that, we could either image where we select a TE where fat and water within a voxel are out of phase with each other, because if they're out of phase with each other, they're not going to create signal within that voxel. Or we could use magnetization transfer coherence. That's where we're actually applying an extra excitation pulse to a resonance off of water. Typically we image on water, the water peak, but we're going to be imaging or applying an RF pulse off of our water peak so that we really saturate that retroorbital fat in structures with really short T1 times. Number 16, using a higher field strength will increase contrast to noise ratio and signal to noise ratio. Is that true or false?
True.
True. So we can better visualize this circle of Willis at a 3T. So imagine this is a 1.5. We can see this, the anterior and the posterior pretty good, right? But as we increase our field strength, where we go up to a 3T, we're going to be able to see even the smaller vessels coming off. So we get better contrast to noise and better signal. The only issue is our SAR limits. We're going to heat our patient up with our higher Tesla magnets. All right, next one. A stenosis is usually under or overestimated in an MRA in terms of signal void.
Under?
What do we think? Can't know that one. Okay, so let's draw it out. You think it's underestimated, okay. Alright, so we have a vessel. And here's the area of stenosis. Could be plaque within that vessel wall. What's plaque within a vessel wall called? Atherosclerosis. So it could be, any type of fat deposit build up within that vessel. Lily, you look confused. You okay? So we have build up within that vessel. Imagine this is the aorta. So we have constant blood flow where we get faster velocities near the center of the lumen and then slower velocities near the wall due to the friction between the blood flow and the wall of the vessel. But this is constant, which is also called what type of blood flow? Laminar. Is that first order, second order, third order? What is that? First. So that means we can actually image laminar blood flow. But then, as it gets to this point where the stenosis happens, so this area, we get signal. So we get high signal intensity up to the stenosis. But then when we go through the stenosis, just like when we have a clamped hose, it's going to increase the pressure within that vessel. So we get what we call accelerated blood flow. Accelerated blood flow is not first order. So we get no signal from this area because it's gone through the stenosis, it's sped up. After it's left the stenosis, we get what we call vortex blood flow, just like when we come to a bifurcation. So anytime we get a stenosis like that, it's going to want to wrap around that area where it came in. So this area right here is our vortex blood flow. Is that first order? No. So we get no signal there too. So here is the actual, in blue, this area right here is the actual stenosis. But on MRI or MRA, this is all of the area that we're going to get that's no signal or signal void. So this is what is actually going to be dark. So is this over or underestimated? So this is overestimated. So the answer is going to be overestimated. Because this is what appears on our MRA imaging. And this is the actual size of stenosis. Okay? So you can see here how our area of no signal is longer than the actual stenosis. Okay? So we're overestimating most of our areas of stenosis. Did you get that? Number 18, what is the best imaging option for the neck, chest, and abdomen where you're going to get a lot of respiratory and swallowing artifact? Which one's the fastest?
Contrast.
Okay.
Contrast enhanced. Remember, this is our bolus injection, where we inject very fast and we image very fast. So we have our tracking, our fluoro tracking. We could have our bolus triggering. All of those imaging options where we are able to image right when it hits that particular vessel. We want to image in the arterial, venous, and the equilibrium phase, which is also referred to as the delayed phase. So if we image very fast, we don't really have to worry about that respiratory artifact or that artifact from the beating heart or that artifact from the patient swallowing, because we're imaging faster than they can actually breathe in, breathe out, or swallow. We still have them hold their breath during those particular phases. Like when you inject, you wait till it hits that abdominal aorta, you see it coming down. You hit the play button to start the pulse sequence, and then right before you hit the play button, you tell them, take a breath in, hold it in. Or right after you hit it, and then you tell them, take a breath in, hold it in, and then it images for like 20 seconds, then you tell them to breathe, and then the venous phase comes up about 30 seconds later, have them hold the breath, and then the delayed phase is 3 to 5 minutes after that. So here are the important technical considerations for our contrast MRA. It is all of the above. Our injection method. Are we going to be hand injecting or power injector? Power injector. What is our typical... That's way too quick. That's like CT stuff. It's 2 to 3 cc's per second. If it's a perfusion study, we usually bump that up to about 3 to 5 cc's per second. And that all depends sometimes on where you place that ID, right? If you place that ID in the hand, and I know Tiffany, you've been up with Miss Deborah, she's doing a perfusion study. She's like, you can't put it in the hand, right? You got to put it in the antecubital because you're injecting so fast that if you put it in the hand, it's more likely to blow.
Right.
Okay? So you put it antecubital where it's able to, fend off that really fast bolus injection. Because that fluid's coming in very rapidly. And when I say blow in IV, that basically means that the catheter comes out because there's so much pressure going in. What it wants to do is just come out of the vessel altogether. And then you get contrast all over your table. Worst case scenario, it causes the vein to rupture, and then all that contrast material and saline goes into their tissue. And it creates that extravasation, infiltration within the tissue, and that can be very painful if you inject very fast and a lot of contrast. Protocol parameters. Basically, we're using an incoherent or spoiled gradient echo pulse sequence, where we're imaging very fast. Dosage, you guys know how to calculate for the contrast dose. Usually 10 pounds equals 1 cc of contrast. And then our scan timing is very fast. Usually we get 1 slice per second. That's why on that fluoro triggering, usually a slice comes up every second. So you see the heart beating. You see the contrast going into the heart, and then coming down, going up the aortic arch, and then coming down the thoracic aorta to the abdomen. You can see it 1 image per second. We're imaging super fast. Number 20, what are methods to increase your likelihood of catching contrast during a bolus injection?
Fluoro triggering and bolus tracking.
Good. Time tracking is not a thing. Time tracking would almost be like what we call pseudo-gating. And what is pseudo-gating? Pseudo-gating is like, remember we had cardiac gating, respiratory gating. All these things are usually planned with our system. Pseudo-gating is really just observing their heart rate and then planning your pulse sequence off of their heart rate. They have 60 breaths per minute. For some reason, we can't get see that elevated R wave on our system, so we just plan it off their heart rate. So that's pseudo-gating. But our best way to catch our contrast is our bolus tracking, fluoro triggering. Fluoro triggering, that's where we're imaging it per second. We're able to see it live, so we can watch that contrast go into the vessels. And bolus tracking is basically we put it right on the abdominal aorta. Has anybody done a bolus tracking? It's usually with a GE scanner. Bolus tracking, you put a little marker right on that abdominal aorta, and it knows once that blood, that contrast has hit that particular marker, we have a signal increase, and that lets the system know to start the pulse sequence. Because our signal is increased within that vessel because that's where we marked where we want that bolus tracking, and then our pulse sequence starts right as the signal increases within that vessel. Number 21, phase contrast MRA provides information about what? All of the above. If you see an all of the above question on the exam, most registries, 90% of the time it's going to be correct. And I'm not going to say 100, but most of the time it's going to be correct. But the main one with this PCMRA is this flow velocity. What's that acronym we need to know about PCMRA? VENC, velocity encoding gradients. So always associate VENC with phase contrast MRA. If you see PCMRA and then your options and you see VENC, once again, 90% of the time that's probably going to be your option.
What's the ENC stand for?
Velocity encoding is an acronym. Gradients. Velocity encoding. The PCMRA provides not only information about the flow velocity, because we can change our VENC to image venous blood flow, which is at like 10 centimeters per second, versus arterial blood flow, which is about 80 centimeters per second. So we can change that. Vascular anatomy and flow direction. Flow direction meaning if a vessel is going this way and our gradients are set up to go that way, our vessel appears bright. But then if the blood flow is going in the opposite direction of how our gradients are set up, it's going to appear dark or black. So we can determine flow direction with our phase contrast MRI. So it gives us a lot of options. So the next one, you're able to distinguish multi-directional blood flow. So we know that's true because we're also concerned with flow direction. All right, to visualize venous blood flow, the operator should select a velocity encoding of what? 10. It's slower, so you select the lower number. Venous blood flow is a lot slower than arterial blood flow. Arterial blood flow usually flows at about 80 centimeters per second. Venous blood flow usually flows at about 10 centimeters per second. So this is why phase contrast is a great imaging option for our superior sagittal sinus, which is a venous structure within the brain. PC MRA also relies on those velocity-induced phase shifts. So it applies these gradients, the V, E, and C gradients, to induce a phase shift of flowing blood. So flowing blood is going to go across a gradient a lot quicker than stationary blood flow, or stationary tissues, which is just kind of stays in the same spot. So as blood flow goes across a gradient, it creates a greater phase shift, meaning it goes from 12 to like 6 o'clock. So anytime we have a phase shift, we'll get bright signal compared to our stationary tissues, which we're not going to get any phase shift at all. So that's why phase contrast MRA is usually our best option for saturating background tissue. So it has the best background saturation out of the group. Those additional bipolar gradients we talked about are those of velocity encoding. PC MRA is used for MRV of the brain. That's true. MRV of the brain is really looking at that superior sagittal sinus, the transverse sinus, and those jugular veins going down. 3D PC MRAs are great for identifying arteriovenous malformations. That's true. Because that blood flow is going in all different directions in those arteriovenous malformations. That's where those are meeting. Arterial and the veins are meeting, and then the blood flow is kind of all twist and turn and going all different directions. All right. So last little bit is going back over that cardiac stuff we covered a couple weeks ago. So which peak triggers the pulse sequence? R wave. So if you had to draw your waves, this is what it looks like. Which is the first wave?
P.
P wave. What's that identify with? Atrial or ventricular contraction? Atrial. It's smaller. So we get atrial contraction or atrial. What's another word for contraction of the heart? Diastole or systole? Systole. Atrial systole. And then we get the big wave, which is our Q, R, S, and that is dealing with our ventricle contraction. And then our next wave, which is our T wave, we don't have any more contraction of the heart because we contracted the atrial and the ventricles. So this is ventricle diastole. So this is where the ventricles are relaxing. You don't see the atrial diastole because that occurs during this time. So this QRS wave covers up the atrial distal diastole. Okay? So we start with our R wave and we go to the next R wave. Okay? That gives us our effective TR. So if we have a patient that has a heartbeat of 60 beats per minute, what is our effective TR? 1,000. So we always do 60,000, so just have that number in mind. There's 60,000 milliseconds in a minute. And then you divide it by the beats per minute. That gives us our effective TR of 1,000. So if we need like a proton density or a T2 weighted image, we need to wait several TR periods or R to R intervals to get our appropriate TR. Okay? What's it called when we get an elevated T wave? So our T wave, when our patient gets put into our scanner, naturally, due to the properties of the magnet, our T wave is going to be elevated. What's that called? Where we get, it looks similar to the R wave, so that's why sometimes it's hard for the system to differentiate the R and the T wave. But what's it called when the T wave is elevated?
Is this the MHD?
MHD, yeah. So what does that mean? Hydrodynamics. Very good. I guarantee you that is going to be a registry question. The elevated T wave is called magnetohydrodynamics. Or magnetohydrodynamic effect. Take the S off. All right, Cine heart imaging uses what?
Retrospective.
Good, retrospective. That's where we're imaging the heart during all the different cardiac phases. That's why with Cine imaging, you can actually see it moving. Prospective, you're just getting images of the heart while it's stationary, while it's not moving. So Cine, it's like a movie, Cine, like cinema, you're seeing the heart move. Retrospective gating. So this is a good image of it. Prospective, or imaging during the available imaging time, where we're not looking at the heart contracting, takes longer because we're doing short bursts of imaging. As opposed to retrospective Cine imaging, where we're imaging during all the phases of the cardiac cycle. It's quicker, but at the same time, we're not able to get the heart stationary. Functionality, Cine imaging. Seeing how the blood flow goes into the ventricles. Does the blood flow go back? Does it go through a septum, like a hole in the septum? Those are good reasons to do Cine imaging. If you're just looking for the wall structure or any type of pathology within those walls, prospective gating is good for that because the heart is still. So you're able to see that pathology a little bit better. I mean, you might be able to see the pathology when it's moving, if it's really big, but most of the time, retrospective is functionality. Functionality imaging. That's why sometimes they call it functional MRI. Functional cardiac imaging. A patient with a fast heart rate, what's another name for fast heart rate? What's a term for slow heart rate? So if they have tachycardia, what will the R-to-R interval be? A short, compressed R-to-R interval. Bradycardia, longer R-to-R intervals. So heartbeat is slower, so you're not going to see that peak of the R wave for a while. That's why you get those people that are starting to code or go out, their heart rate slows down to the point where it just flatlines. A very fast heart rate, imagine somebody just saw a zombie, peak R waves happening a lot faster. Come on, you like how it incorporates in Halloween. Alright, 31. What is the effective TR of a patient with a heart rate of 70?
857.
857. So just 60,000 divided by 70. Alright, this would be really good to write down. Something we didn't really cover. So if the test or the registry asks you, how many cardiac phases are we able to see with a patient that has a heart rate of 70, this patient, and a TR of 25 milliseconds? So once again, if a question asks, how many cardiac phases can we see with 70 BPM? 70 BPM, I'm not going to write that one again, and TR 25 milliseconds. So to get that answer, we basically do our effective TR conversion. So we have our 60,000 divided by 70, which we have said gives us that 857. And then all we have to do is divide that number by our TR. And that will give us the amount of cardiac phases. So what is that number?
34.3.
Good. So let's just round up to about 34, or round down, 34 cardiac phases. So that's how many different images of the cardiac, of the heart, within all those different phases. So we slightly contracting, more contracting. So we get all these different phases. So it's a two-part question. All right. Next one, we already answered this. As we start to get multiple R-to-R intervals, it gives us longer TRs. Longer TRs are always associated with T2 and proton density. Short TRs associated with T1. Remember, proton density is a long TR, short TE. T2 is long TR, long T. T1, short TR, short T. So as our TR gets longer, you get more proton density and T2 weight. Our safeguards built in so that we don't get motion on our image for prospective gating. Those are our trigger delay and our trigger window. Those are our safeguards. And then our acquisition window is basically the available imaging time. That's not our safeguard. Trigger delay is usually in milliseconds, and trigger window is expressed in a percentage. All right, so how do we calculate for 34 and 35? Heart rate's 80 beats per minute. So first thing we need to do is 60,000 divided by 80. That gives us what? 750. And then we need to subtract our trigger window and our trigger delay. What is our trigger delay underneath there? Our trigger delay is 40. Plus, what's 15% of 750?
112.5.
112.5. So now add 40 to 112.5. Gives us 152.5. So 70 minus 152.5 equals what? 597.5. And it's in milliseconds.
On this quiz, it wouldn't let me type in milliseconds. It wouldn't let me type in
Okay.
milliseconds.
So I'll go back. If for some reason if you didn't put the milliseconds, I'll give you credit. If the time is right.
Yeah,
you
it
just
said
do-
it wasn't valid because when I typed in milliseconds, it just erased my whole answer.
Yeah.
And said not valid.
So you were able to put a time.
It just
You could just put
you can't
numbers.
give me letters.
Well, it says unit already in milliseconds, so I guess you don't even need to put the milliseconds.
I know. I can see my Wi-Fi answer.
All right. So the next one's a little easier just because it's 60 beats per minute. So we get 60,000 divided by 60, which equals 1,000. And then we subtract 60 plus 100. Or no, trigger window's 20, so 200, right? And that gives us what? 740? All right. Last little bit. Patient care question. If you have a patient and for some reason you're not getting a good heartbeat, what are some tips to get a better reading with your ECG, your MRI safe ECG? Imagine it's a male patient that's got a very hairy chest. What would be some tips? Shave the area. Do you ever reposition the leads once you stuck it to them?
No.
No, you get just a new little sticky because once you've taken them off and then try and put them back on, they're not going to stick as well. Where do you place them? You have the 4 colors. Where do you place them? Right side of the patient, left side? Heart is typically going to sit right here on the left side. Left side. What are our colors? What's above and below?
Black, red.
Black above red on the outside, more lateral. But what's midline? More midline. Yeah.
Brown.
Not brown. Not
White above green.
white above green. White, green, black, red. Right at the nipple line. The bottom of those 2 leads at about the nipple line or right below it. The other 2 above the nipple line. So left side of the patient, find the sternum. Put the 2 leads, put the green and the red below the nipple line. White and black above the nipple. Shade the area, make sure it's not wet, and never reposition those leads. If that doesn't work, what's the gating where we clip it to our finger? Huh? It's the pulse ox, which is peripheral gating, because we're looking for perfusion within those capillary beds, peripheral gating, or if all else fails, pseudo gating, where you get their heart rate and time it off their heart rate. So one thing I want to add to this chart here is, yes, we're only really able to image first order laminar blood flow. But another thing to remember is we get flow-related enhancement. Flow-related enhancement is maximized when flow is, what do you think, parallel or perpendicular to our slices? It's going to be perpendicular, because parallel would give us saturation, perpendicular gives us flow-related enhancement. Okay, so that's another thing to remember. What is the difference between MIP and NPR? You guys always do this in your post-processing. What's the difference?
MIP is like segmenting, like taking away. The MIP is
Segmenting? Good.
Yeah, taking away.
What are you taking away, Tiffany?
Like
Flow or stationary tissue?
stationary tissue.
Good. All that background tissue, right? So MIPing, maximum intensity pixel. Remember, it's a collapsed image, and it gets recreated through the algorithm, the digital array, and it creates this image that we can turn all different directions, right? And then that's where you can segment out the anterior from the posterior, and then spin it, tumble it, things like that. What's NPR? What's that stand for first?
Multi-planar reconstruction.
Yep. Good. Multiplanar reconstruction. NPR. Multiplanar. So if we acquire, most of the time on our brain exams, we get a 3D sagittal. That's usually our last image, right? NP range. You guys have seen that, right? Mm-hmm. NP range of the sagittal brain. So then which are the two planes we need to reconstruct it in? We have a sagittal. Coronal and what? So we have now a sagittal, we have a coronal, and then axial. So we always need to NPR our sagittal NP range to a coronal and an axial. And that is allowed because we have isotropic voxels, meaning our voxels have the same dimension on all three sides. Okay? If you guys have any questions, that completes our review for the exam this weekend. So if you have any questions, let me know now. So remember,
Please open it.
yes, I'll open it up so you can look at it again. Use the chart, use the quiz, study off that. The echo lectures, you can go through sample registry questions. Work on the effective TR, available imaging time worksheet that we went over. All right, that completes our lecture.